Welcome to this educational program. This module discusses a surgical treatment for kidney cancer called partial nephrectomy, a type of kidney-sparing surgery. A separate presentation entitled Understanding Kidney Cancer is also available, and it is hoped that you will have viewed this module already. The information in this presentation is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. Partial nephrectomy involves the selective surgical removal of a kidney tumor, along with a small amount of surrounding normal kidney tissue. In this way, most of the kidney tissue is preserved to maximize overall kidney function. This procedure is done in the following situations. Firstly, for the removal of benign or non-cancerous tumors, and secondly, for the removal of malignant tumors, when the other kidney is missing or has poor function, when the other kidney is at risk of damage later from diseases that can cause kidney failure, when tumors must be removed from both kidneys, and when the other kidney is normal, but the tumor is small, usually less than 4 centimeters, and localized. In all of these instances, the procedure is both diagnostic, making the diagnosis of benign versus cancer, and therapeutic, since it is intended to cure the cancer. The kidneys are a pair of bean-shaped, fist-sized organs situated on either side of the spine in the upper abdomen and lie behind the bowel and other abdominal organs. They are protected by the lower part of the rib cage and the spine. They are composed of many different types of tissues and cells, but broadly they consist of a filtering system, the meaty red part of the kidney called the parenchyma, and a drainage system that carries urine from the kidney down to the bladder. The renal parenchyma is divided into an outer part called the cortex, which is the filtering mechanism, and an inner part called the medulla, which is the collecting area for urine. It is easy to think of the kidney as an organ where blood goes in and urine comes out. Above each kidney lies an adrenal gland, and each kidney and adrenal gland is surrounded by fatty tissue, which is a protective mechanism in place so that the kidneys do not get damaged by trauma, such as jarring accidents and direct blows. The fat acts as a shock absorber for the kidney. It also acts as a natural barrier preventing local extension and spread of kidney cancers. Around all of this is a tough fibrous membrane called Gerota's fascia, which is also important in limiting the spread of cancer. Like all major organs, the kidneys are also surrounded by lymph nodes, small glands that play a central role in fighting infection and disease. The kidneys receive blood supply from usually one, but often 2 or more renal arteries, which arise from the aorta, the largest artery in the body. This is the large blood vessel that takes blood away from the heart and to the rest of the body. Blood drains out of the kidney through 1 or more large renal veins, which then drain into the largest vein in the body, called the inferior vena cava, or IVC, that drains blood from the body back to the heart. This drawing shows how the kidneys are surrounded by other organs in the body. On the right, the kidney sits below the liver, next to part of the small bowel called the duodenum, and beneath the right side of the large bowel, or colon. On the left, the kidney lies below the spleen and stomach, beneath the left colon, and just to the right of the pancreas. The lungs and chest cavity are also in close association with the kidneys. This is what the kidneys and other organs look like on a CT scan or MRI, where the body is viewed in slices, like cutting someone in half and looking up from the feet. Kidney cancer usually begins in the cortex of the kidney. As it grows, it is initially limited by the capsule of the kidney, then the fat, and finally Gerota's fascia. It also may grow into the adrenal gland, or into the renal vein, and even the inferior vena cava. Furthermore, it may spread into the lymph system and the lymph nodes, or into the blood vessels and out to other organs in the body. These patterns of growth and spread determine how kidney cancer is staged, which determines how it is treated. As noted, partial nephrectomy involves removal of a localized kidney tumor along with a small amount of surrounding normal kidney tissue. This surgery can be performed through a traditional open incision or cut in the skin, or through telescopes called laparoscopic surgery. The traditional open surgical approach is chosen for very large tumors, tumors that have advanced locally into other adjacent organs or renal veins and IVC, tumors that have grown more centrally into the inner part of the kidney, when previous surgery or other circumstances would make laparoscopic surgery difficult, or when the surgeon is simply more comfortable with the open surgical approach. Because partial nephrectomy can be a more complex operation than complete removal of the kidney, certain technical obstacles in doing this operation laparoscopically have been challenging to overcome in the past. At the time of preparing this presentation, most partial nephrectomies are still being done through an open incision. However, the number of laparoscopic cases is increasing quickly. Prior to coming to surgery, you will meet with your urologist, who is a surgeon specializing in the kidneys and urinary tract. A medical interview will be carried out, and your medications and allergies, etc., will be reviewed. A physical examination is performed. Then testing may be ordered to assess the kidney cancer and your fitness for surgery. This testing may include blood and urine tests, and a cardiogram to check your heart. Imaging, such as X-rays, CT scan, or MRI may also be performed. Staging will be performed by the physical assessment, blood tests, and imaging studies to determine if the cancer is localized or is spread elsewhere in the body. These findings are then reviewed, and treatment options, including surgery, are discussed. If you have any concerns, they should be reviewed at this time. Be sure your doctor is aware of all your pertinent medical information, especially regarding the taking of blood thinners that are prescribed or over the counter. Ask about your medications, including what you should continue taking up to the time of surgery. Following this review, you will be asked to sign informed consent for surgery. This is a very important document which indicates that you understand why surgery must be performed, other treatment options, what surgery entails, and what the potential risks are. The side effects of surgery are clarified here, and you should review this before signing. The consent also allows your doctor to perform any other procedures that are deemed necessary to save your life, and to use the assistance of other medical personnel, such as other doctors, nurses, and students. Finally, the consent normally includes a note that allows your doctors to use blood or blood products if deemed necessary to save your life. If you have an objection to this, you must notify your doctor and have this section adjusted accordingly. Once the decision is made, it is time to prepare for surgery. In the days leading up to the operation, focus on living as healthy as you can, eating a balanced diet, and getting some regular exercise. Also very important is smoking cessation if you are willing to try this at this point in your life. It has been found that if you stop smoking just prior to surgery, there are distinct benefits regarding anesthetic risk and recovery from surgery. Gathering the support of friends and family around you, as well as other patients who have had the operation when possible, can help ease your mind and comfort you. Try to take other measures to reduce stress as well. Arrange time off work well ahead of time, and organize some help with household and other tasks before and after surgery. Learning about your condition and your surgery through programs like this can also help to relieve anxiety by removing the mystery of what is happening to you. Finally, it is important to understand and come to terms with the expectations of surgery as well as the potential outcomes. The night before the operation, eat a light meal, then take nothing by mouth for several hours before surgery. A common instruction is to take nothing by mouth after midnight on the night before the operation. However, individual instructions will vary and may include a bowel preparation. Try to get a good night's sleep, as it helps to go into surgery well rested. Finally, as individual situations will differ, follow the advice of your doctor or hospital regarding specific preoperative instructions. On the day of surgery, have someone drive you to the hospital and try to arrive early. You will likely first go to the admitting department and have some paperwork done to check you into the hospital. You will then be checked into the surgical area, where you will change into a hospital gown and meet with the nurse. The nurse will review your medical history and check your vital signs, including your blood pressure, pulse, and temperature. An intravenous or IV line will likely be started, through which you will receive fluids and later medications. At some point during this process, you will meet with an anesthesiologist, who will administer anesthetic drugs and monitor your vital functions during surgery. The anesthesiologist will review different anesthetic options for you and discuss their merits and potential risks. A common part of the anesthetic regimen used during a nephrectomy is an epidural line, which allows the doctor to give drugs directly into the spinal cord and nerve roots to provide excellent and focused pain relief. This will be discussed and is also reviewed in its own module. Finally, prior to surgery, you will meet once more with your surgeon, and any final concerns can be addressed. If not done already, the site of surgery may be marked as a safety precaution to ensure that the correct kidney will be operated on. Once in the operating room, an intravenous or IV line will be started if not done already. As mentioned, an epidural catheter may also be inserted. You will then be put to sleep by the anesthesiologist, and a breathing tube will be introduced. Other tubes and monitoring lines may then be placed, including a catheter into the bladder to monitor urine output, an arterial line into your wrist to monitor blood pressure, and a central venous line in your neck for monitoring and for giving fluids. Other monitoring devices are also used to check your level of blood oxygen, your temperature, and your level of anesthesia, among other things. The doctors and nurses will then carefully position you on the operating table in such a way as to optimize the ability of the surgeon to carry out the operation. This drawing shows the most common position, with the patient on her side and the table bent in the middle. Once positioned, the skin is cleaned with special antibacterial solution, and an incision or cut is made. There are some choices of incision for partial nephrectomy. However, most commonly, a 6 to 12-inch incision is made diagonally across the flank, along the direction of the ribs, from the middle of the rib cage to the front of the abdomen. In this approach, a piece of one rib may or may not be removed to allow access to the kidney. The chest cavity and abdominal cavity are rarely opened during this process of gaining access to the kidney. In fact, this happens less than 5% of the time. After gaining access to the kidney, the surgeon will open Gerota's fascia and clear the fat away from the kidney except for that over the tumor. The renal blood vessels are identified and temporarily clamped to stop blood flow to the kidney. Special medications to preserve the kidney may be given prior to this. The kidney may then be cooled down with ice slush for several minutes to protect it from the effects of having its blood supply temporarily occluded, especially if the blood flow is to be disrupted for greater than 30 minutes. Next, the kidney capsule is cut around the tumor, leaving a margin of about 1 centimeter away from the tumor, and the tumor and surrounding small amount of kidney tissue are shelled out. Some surgeons may use ultrasound to help localize the tumor in certain situations. At this time, a special examination of the specimen, called a frozen section exam, is carried out by a pathologist. This special technique allows quick processing and immediate examination of the specimen, so that the pathologist can report back to the surgeon in the operating room as to the diagnosis of the tumor and whether clear margins have been achieved all around the tumor and how wide those margins are. This helps the surgeon decide if any further resection is required. While the frozen section is extremely helpful, more detailed information about the specimen requires more extensive processing and examination, and a final report will still be issued at a later date. Back in the operating room, if the tumor grew deep into the central part of the kidney, the drainage system of the kidney may have been opened, and this will now have to be closed. In these cases, a drainage tube called a stent may sometimes be placed, and your doctor will need to remove this at a later date. Bleeding is now controlled by sewing over any open blood vessels. Clamps are removed to allow blood flow back into the kidney. The kidney is then sewn back together to close the gap created by removing the tumor. Occasionally, fat or blood clot promoting agents are used in the defect of the kidney to promote clotting and allow for tension-free kidney closure. Finally, a drain tube is placed to keep fluid from collecting after surgery. This tube is brought out through a separate small incision in the abdominal wall away from the surgical incision. The incision is then closed, using several layers of sutures on the inside and staples or stitches in the skin. A dressing is applied to cover the incision. If necessary, in rare cases, a chest tube may be placed during the closure process to drain fluid from the chest cavity and prevent air from collecting between the lungs and the chest wall. This is rarely needed and occurs in less than 5% of cases. Once stable, the patient is transferred to recovery area for further monitoring, and eventually to a regular ward bed. In rare situations, such as with significant blood loss or an operation on a solitary kidney, patients will initially be monitored in an intensive care unit. For the first couple days after surgery, you will usually not be allowed anything by mouth and will not be able to move around too much. For this reason, you will have special compression devices on your legs to prevent blood clots from developing. A catheter or tube will drain urine from your bladder into a bag to monitor your urine output. As mentioned, a chest tube may also be present. Pain control can be managed either through an epidural catheter or through an intravenous line. After a while, once you begin to move gas through your system, you'll be allowed to take in clear fluids and progress slowly up to a full diet. Activity will also be gradually increased, initially involving just sitting at the bedside, then getting up and moving around with assistance. The compression devices will stay on until you are moving around well and the risk of blood clots has diminished. Pain control will eventually progress from drugs given through the epidural or the IV to oral pain medications. The bladder catheter is removed once the epidural is out and you are moving around well. The drain tube comes out when the amount of fluid it drains is satisfactorily low. If present, the chest tube is taken out when the lungs are expanded and all fluid is removed. Staples or stitches are usually removed before going home. You will be allowed to go home once your doctors and nurses are satisfied that all vital signs are stable, your bowels are working, no tubes or IV lines are in place, you are comfortable using only pills for pain control, and you are moving around well. Once you go home, keep physical exertion to a minimum in the first couple weeks, and take care to get plenty of rest, eat a healthy diet, and keep stress to a minimum. Continue smoking cessation if stopped prior to surgery. Your doctor can prescribe medications and routines to help with this in the postoperative period. Gradually return to full activities by 6 to 8 weeks. Understand that it may take some time to feel that you are back to normal again. You may not be able to focus and concentrate as sharply as normal, and your physical energy and stamina may be diminished for several weeks. Sometime after you return home from hospital, you will need to visit your doctor for a follow-up. At this visit, your doctor will check the healing of your incision and will discuss the pathology report with you. This is the final report issued by the doctor in the lab, the pathologist, who inspects the kidney and tumor and examines it under a microscope. The pathology helps your doctor to decide on your follow-up schedule if necessary, and if any further tests will need to be done in the future. If necessary, further treatment will be organized, and plans will be made for regular follow-up visits. Most kidney cancer patients undergo a regimen of regular follow-up examinations after surgery, including periodic assessment by a physician, kidney and liver blood tests, X-rays, and ultrasound or CT scans. The exact schedule of follow-up visits will depend on your specific clinical situation, as well as the preference of your doctor. Obviously, the greatest concern for patients undergoing partial nephrectomy for kidney cancer is that the cancer be cured. Kidney cancer, in fact, most definitely can be cured with this operation. It is important to understand that the word cure is a difficult term to define and varies with different types of cancer. For kidney cancer, cure is generally defined as no evidence of recurrent disease after 5 years of close follow-up. However, later recurrences can occasionally happen. It is for this reason that careful follow-up monitoring is so important. Tumor recurrence is less likely for tumors of smaller size, lower stage, and lower grade. For isolated tumors less than 4 centimeters in size, the recurrence rate in the same kidney is said to be 2% or less, and the cure rate should be 75 to 95%. If kidney cancer does recur, treatment options exist, and these may include further surgical removal if there is only 1 or 2 isolated tumors, radiation therapy if it appears in the bones, and/or biologic or targeted therapy if the cancer is spread outside the kidney. The next several slides will discuss the potential risks of surgery. For most patients, partial nephrectomy is a straightforward and safe procedure. However, it is considered major surgery, and for some patients the situation can be complex. Overall, there is a very small risk of death during partial nephrectomy of less than 2%. Most of these likely occur in more complex cases with high-risk patients and large or advanced tumors. The risk of death should be less for smaller, more localized tumors. Causes of death may include things such as excessive bleeding, heart attack or heart failure, blood clots to the lungs, injury to other organs around the kidney, pneumonia or other infections, and kidney failure. This slide outlines the potential problems that may be encountered in the operating room during surgery. Since our kidneys filter our blood to produce urine and receive 25% of blood pumped by each heartbeat, significant bleeding to the point of requiring a blood transfusion can occur in about 5 to 10% of cases. For this reason, blood is routinely kept available to transfuse as necessary. Several other organs are located near the kidney, and these may occasionally be injured during partial nephrectomy. These include the bowel, spleen, pancreas, and stomach on the left, and the bowel and liver on the right. These injuries are uncommon and usually recognized and repaired at the time. Rarely, removal of the spleen, or splenectomy, and resection of the tail of the pancreas is required during left-sided surgery, but usually only if the tumor is locally advanced and will require complete removal. The lining of the chest cavity, called the pleura, may be cut or punctured during surgery. This may require a chest tube afterwards. Again, this is a rare occurrence. If a puncture is not recognized, or if a chest tube is not left in place, this can rarely lead to what is called a pneumothorax, which is air in the chest cavity outside the lungs. This can put pressure on the lungs, making it hard to breathe, and is treated by placing a tube in the chest to let the air out. Risks of general anesthesia will be outlined by the anesthesiologist and are discussed in separate modules. There are also certain rare risks associated with the special positioning on the operating table, such as nerve damage, pressure sores, and back problems. There are other rare complications that may occur in the first few days after surgery. These include infections of the bladder, wound, abdomen, bowels, or IV sites, ongoing bleeding from inside the abdomen or from the wound, and lung problems, such as an unrecognized pneumothorax, temporary poor lung function from collapsed areas called atelectasis, and pneumonia. Some patients experience slow return of bowel function because the bowel is temporarily paralyzed, called an ileus. Pancreatitis or pancreatic fistula are very rare complications of partial nephrectomy, caused by injury to the pancreas with a leak of pancreatic fluid into the abdomen or through the skin incision. A collection of infected fluid in the abdomen, called an abscess, can occur from an unrecognized bowel injury. If the opposite kidney is absent or does not have optimal function, there may be a temporary decrease in overall kidney function, or even kidney failure requiring dialysis. Urine may leak out of the kidney and collect around it, and this is called a urinoma. Similarly, blood can collect around the kidney, and this is called a hematoma. Urine can rarely drain out of the kidney and through the wound. This is called a fistula. The drain that is placed at the time of surgery is there to prevent these collections from forming and becoming infected and forming an abscess. The tube that drains urine from the kidney to the bladder, or ureter, can become temporarily blocked by a blood clot, which may require an intervention to clear the blockage. Wound infections are an occasional risk of any surgical procedure and are usually prevented by antibiotics given to you prior to starting your surgery. Finally, blood clot in the legs, called deep venous thrombosis, or in the lungs, called pulmonary embolus, may occur from poor venous circulation during and after surgery while the patient is immobile. This potentially fatal complication can occur with any operation, and measures are taken to prevent it, including the use of special compression devices on the legs, drugs to prevent clotting, and early mobilization. This problem may occur while in hospital or rarely after discharge home. Other potential problems that can occur later are listed here. Minor problems with the incision are not uncommon, such as bulging of the muscle or numbness of the skin around it. This is caused by damage to a nerve that runs under the rib cage to the front of the abdomen, which often must be cut to gain access to the kidney. Actual hernias of the wound, where abdominal contents bulge into the wound under the skin, are rare. Delayed kidney failure may occur in cases where much of the kidney had to be removed, and when ongoing kidney disease causes further worsening of function. Lastly, as noted, cancer may sometimes recur. Once home from surgery, please call your healthcare provider right away if you develop a fever, if you become nauseated or start to vomit, if you have uncontrollable pain, if you develop a cough or become short of breath, if you develop swelling or tenderness in the legs, if you develop chest pain, if you have trouble urinating, or if your incision becomes red, tender, or swollen. In summary, partial nephrectomy involves the removal of a kidney tumor and part of the surrounding kidney. It is performed with the goal of curing, or at least controlling kidney cancer, or to remove non-cancerous lesions of the kidney. It is considered major surgery, and as such, a hospital stay is required. It is performed through an incision in the side of the abdomen. It is important to understand several important risks of this operation, as outlined in the presentation. Most patients recover well from surgery, and in most cases, the cancer can be cured. These are just a few of many resources available to educate you on kidney cancer and help you find support. These references were also used to assist in preparing this presentation and are available at your local medical library. We sincerely hope that this module has furthered your understanding of partial nephrectomy for kidney cancer. We wish you the best for the future, and thank you once again for viewing this educational program. Tumors. When the other kidney is missing or has poor function, when the other kidney is at risk of damage later from diseases that can cause kidney failure, when tumors must be removed from both kidneys, and when the other kidney is normal but the tumor is small, usually less than 4 centimeters, and localized. In all of these instances, the procedure is both diagnostic, making the diagnosis of benign versus cancer, and therapeutic, since it is intended to cure the cancer. The kidneys are a pair of bean-shaped, fist-sized organs situated on either side of the spine in the upper abdomen and lie behind the bowel and other abdominal organs. They are protected by the lower part of the rib cage and the spine. They are composed of many different types of tissues and cells, but broadly they consist of a filtering system, the meaty red part of the kidney called the parenchyma, and a drainage system that carries urine from the kidney down to the bladder. The renal parenchyma is divided into an outer part called the cortex, which is the filtering mechanism, and an inner part called the medulla, which is the collecting area for urine. It is easy to think of the kidney as an organ where blood goes in and urine comes out. Above each kidney lies an adrenal gland, and each kidney and adrenal gland is surrounded by fatty tissue, which is a protective mechanism. This program is strictly informational in nature, and no attempt is made to provide opinion or recommendation. Please feel free to view this presentation as many times as necessary. You may also use the player on your left to repeat slides or to skip through them in any order you wish. Partial nephrectomy involves the selective surgical removal of a kidney tumor, along with a small amount of surrounding normal kidney tissue. In this way, most of the kidney tissue is preserved to maximize overall kidney function. This procedure is done in the following situations. Firstly, for the removal of benign or non-cancerous tumors, and secondly, for the removal of malignant tumors. Welcome to this educational program. This module discusses a surgical treatment for kidney cancer called partial nephrectomy, a type of kidney-sparing surgery. A separate presentation entitled Understanding Kidney Cancer is also available, and it is hoped that you will have viewed this module already. The information in this presentation is taken from a recent review of the medical literature and attempts to be as comprehensive as possible. However, it may not necessarily reflect the experience of your healthcare provider or the specifics of your situation in place so that the kidneys do not get damaged by trauma, such as jarring accidents and direct blows. The fat acts as a shock absorber for the kidney. It also acts as a natural barrier preventing local extension and spread of kidney cancers. Around all of this is a tough fibrous membrane called Gerota's fascia, which is also important in limiting the spread of cancer. Like all major organs, the kidneys are also surrounded by lymph nodes, small glands that play a central role in fighting infection and disease. The kidneys receive blood supply from usually one, but often two or more renal arteries, which arise from the aorta, the largest artery in the body.